Good morning to all. Am I audible? I'm going to present. Thank you, sir. I'm going to present the topic Iceberg on behalf of Chittoor Medicine. A 27-year-old gentleman, Mr. B, graduate from the Chittoor, presented with the complaints of fever since 10 days and abdominal pain since 3 days and vomiting since 3 days. And history of personal illness, he was apparently well until 10 days ago. He developed a fever at the intermittent high grade and with associated with chills and more at night. He had a complaints of abdominal pain since 3 days, moderate pain, intermittent, not radiating in nature, and no aggravating or relieving factors. He had a complaints of vomiting for the past 3 days, 3 episodes per day, watery, contaminated with food products, non-projectile, non-bilious, non-blood stain. He also had a complaints of cough without expectoration for the past 1 day, associated with the discomfort in swallowing food. There was no history of chronic cough, sputum production, or breathlessness. There was no history of diarrhea or jaundice. There was no history of palpitation, chest pain, pedal edema, orthopnea, or paroxysmal nocturnal dyspnea. There was no history of bloody or frothy urine or decreased urine output. There was no history of Raynaud's phenomenon or painful lumps below the skin surface, joint pain, photosensitivity. There is no history of outside travel. There is no history of exposure to domestic animals or pets. On examination, the vital signs, pulse rate was 132 beats per minute, regular in rhythm, all peripheral pulses were felt. BP was 90-60, respiratory was 32 cycles per minute, saturation was maintaining at room air, and the temperature was 101 degree Fahrenheit. He was presented with the pallor and icteric also was present, no cyanosis, no clubbing, no pedal edema, no generalized lymphadenopathy. On CV's examination, SNS2 had no murmur, RS was trachea in central position, bilateral normalized response here, coarse crepitation here over the bibasal lung regions. Per abdomen, soft hepatomegaly and splenomegaly was there, and no tenderness, no shifting dullness. On central nervous system examination, power was 5/5, tone normal, bulk normal, dependent reflexes 2+, no sensory or cranial or cerebellar deficits. The syndrome complex of this patient, fever plus abdominal pains, vomiting, pallor plus ectric hepatosplenomegaly. With the syndrome complex, our differential diagnosis were infections, tuberculosis, brucellosis, syphilis, cytomegalovirus, hepatitis virus, malaria, leishmaniasis, malignancy, leukemia, Hodgkin's or non-Hodgkin's lymphoma, sickle cell disease, thalassemia, primary liver tumors, metastatic carcinoma, inflammatory disease, systemic lupus erythematosus, amyloidosis, sarcoidosis, and Gaucher's disease. An initial evaluation, CBC showed hemoglobin was 3.2, MCV was 78.7, MCH 27, total leukocyte counts were 1600, differential counts were neutrophils are 63%, lymphocyte 10%, and platelets are 90,000. And urine routine showed WBC was 0 to 1, no proteinuria, and LFT was total bilirubin level was 3.06, direct bilirubin level was 1.49, with alkaline phosphatase were elevated up to 736. A renal function test for creatinine was normal, and serial blood culture results also showed negative, and LDH shows 300, and reticulocytes were 5.53, and ANA was negative for the patient, DCT also negative, C3, C4 were within normal limits. Sputum AFB negative, expert TB PCR also was negative, MGIT no acidosis was seen, and rapid BBB is showing HIV-1 positive for this patient, and malarial parasites also negative. And further evaluation, CD4 count shows 5 cells, CD4 count percentage are 4% only for this patient, and stool special parasites also for negative, and serum cryptococcal antigen also for negative for further opportunistic screening. And ophthalmic evaluation showed CMV retinitis, Visapy retinopathy, and syphilis screen ELISA also came as a positive for this patient. And USG abdomen and CT abdomen also showed hepatosplenomegaly with ascites and bilateral pleural effusion. So with this finding, the pancytopenia for further evaluation, we did a bone marrow It showed the patients with the presented with the classical Hodgkin's lymphoma with the 40 to 50% infiltration. The CD30, PAX5, CD15 were positive for this patient. I'm going to discuss the topic about the HIV-associated malignancies. The most common malignancy associated with the HIV is Kaposi sarcomas, non-Hodgkin's lymphoma, invasive cervical carcinoma. Non-AIDS defining malignancies were more common in the Hodgkin's lymphoma, multiple myeloma, leukemia, melanoma, and cervical, brain, testicular, oral, and lung cancer, and gastric cancer, liver cancer, renal, and anal cancers. Introduction of potent antiretroviral therapy marked reduction in the incidence of Kaposi sarcoma. Non-AIDS defining malignancies occur more morbidity and mortality in patients with HIV infection than the AIDS defining malignancies. It holds 10% of deaths in the patient with the HIV infections. The HIV-associated malignancy, the meta-analysis in the study also shows that meta-analysis of the incidence of non-AIDS cancer in HIV-infected individuals. In this objective, we estimate that standardized incidence ratio of non-AIDS AIDS cancer among the HIV-infected individuals compared to the general population rates were compared with that. And the design also the meta-analysis using the standardized incidence ratio of 18 studies from the non-AIDS defining cancers in the HIV-infected individuals. The criteria for this study was comparing the rates of the non-AIDS cancer in the people with the HIV to those in the general population. They used data from the cancer registry and SEER program. They only included study. They did not overlap with each other. They searched articles from the PubMed or Embase. The search was between the November 2007 and March 2019. The results for the study for standardized incidence ratio for that HIV infected patients with the malignancies were anal cancer were 28, Hodgkin's lymphoma were 11, and liver cancer was 5.6, and lung cancer also was 2.6. And AIDS was associated with the greater standardized incidence ratio for the Hodgkin's lymphoma and leukemia, lung and brain cancers, and all non-AIDS cancer combined. Another one study also done in the 2022. It is systematic review of a meta-analysis to estimate the summary of risk of the incidence and mortality of the wide range of non-AIDS defining cancers among the patients living with HIV compared to the general population. The search also made on the PubMed Embase Cochrane Library. It was published before Jan 24, 2022. The study also simply reporting the outcomes of the cancer progression lesions and combined with the non-AIDS defining cancers were excluded. The interpretation of the study were patients living with the HIV are increased incidence and mortality for a wide spectrum of non-AIDS defining cancers. The study method was totally 23,450 publications were identified. From that, they are secluded as 47 studies in this meta-analysis. And this final result, it showed a patient living with the HIV are more likely to die from the anal cancer and Hodgkin's lymphoma and liver cancer and lung cancer and skin melanoma in comparison with the general population. And study also found that non-AIDS defining cancers with an infectious etiology occur at a greater risk among the HIV patients than the general population. Cancers are related with the infection more commonly in the human papilloma virus, Epstein-Barr virus, and hepatitis B and hepatitis C virus. The Hodgkin's lymphoma in HIV patients, it occurs in at moderate levels, moderate level of immunosuppression in the HIV patients. Risk increases when the CD4 count also will decrease. Hodgkin's lymphoma is the most common in patients with the CD4 count was 200 to 350 cells. The Hodgkin's lymphoma in HIV patients differ from the HIV native patients by the HIV positive patients are more aggressive etiology. They will be presented with the mixed cellularity variant and lymphocyte depleted variant of Hodgkin's lymphoma. And non-arbor stage diagnosis is higher in the HIV positive Hodgkin's lymphoma patients. And B symptoms, drenching or fever, 10% of loss of total body weight are more common in the HIV positive Hodgkin's lymphoma patients. The treatment are adriamycin, bleomycin, vinblastine, doxorubicin for the HIV positive patient with advanced stage Hodgkin's lymphoma. And also the antiretroviral therapy also can be given safely together. The patient also treated with the trimethoprim, sulfamethoxazole or pentamidine for the pneumocystis jirovecii prophylaxis. Patient with advanced HIV infection, if the CD4 count of less than 15 prior AIDS defining opportunistic infection, or performance status are more than 2, those patients were treated with 6 to 8 cycles of ABVD with the antiretroviral therapy. Management of HIV Hodgkin's lymphoma in this, the guidelines from the European Society of College of Oncology, they are classified as a limited stage and intermediate stage, advanced stage. Thank you. The learning points of the patients are more commonly in the HIV associated malignancy in the patients of the patients living the AIDS.
Okay, Dr. Vivekananthan. Any questions, Dr. Vivekananthan? One question, your patient had any chronic symptoms. All symptoms are fever, abdominal pain, and vomiting for 10 days is what you have present.
So he had present. He was never hospitalized before. Also, ever diagnosed before, sir. The onset of symptoms also was the history of only for 10 days. The chronic history and also high risk history also we could not obtain from the patient also.
The examination you have hepatosplenomegaly was, mild, moderate. How was it like?
Sir?
How was your hepatosplenomegaly? Was it a big liver, spleen, and all?
Moderate splenomegaly was there, sir.
Okay, because like all your symptoms were mostly 10-day symptoms, but your differences were like disseminated tuberculosis, periodosis, and all those things were there.
Yes. And sir, we have done for that is TB screening also in the bone marrow and induced sputum also. It all came as a negative, sir. After that only we ruled out the TB. And we started on that opportunistic infection prophylaxis also. And for the hematological disorder, we refer the patient with where the NACO will be provide the free treatment for the patients.
Thank you.
Thank you.
I'm sure we have an exciting or interesting cases which are presented. I would like to give the prize to Dr. Divya for the assignment of the side which I'm also to give the Thank you, everyone.